Well, thank you very much, Professor Goldenberg, and thanks for the invitation. It's really a great honor to be here, and thanks for getting up so early in the morning to hear grand rounds from an Englishman that's been polluted by the American accent. So I appreciate that. Let's see if we can get this going. First of all, you know this scene, and all of us at the Mason Clinic wanted to say thank you so much. These are your colleagues and friends, I know, so I wanted to show you this with Gibbons and Korea, and everybody I meet and bump into in the hallways that heard I was coming here said, just say hi. So a warm felt hi from some of your friends at the Mason Clinic. Today I'd like to look at the dilemma that we face in terms of diagnosing prostate cancer. And I thought I would pick out this and give you a snippet of the direction I'm taking in terms of some of the research I'm doing looking at diagnosing prostate cancer. And the way I'd like to set it up for you today is to set it up so that to present you with the dilemma, to present you with the problems, some of the problems with PSA, and then to give you an idea of some of the problems of who do we biopsy? You know, really ask that question to yourself. And then once you know who you're going to biopsy, how do you know where to biopsy them? So these are fundamental questions I'd like to pose to you, and see if I can give you some of the answers that we're trying to come up with. And here's the problem. You know, prostate cancer is remarkably common, 1 in 6 men. We have quite a sensitive test to pick it up, but it's not very specific. So maybe it's an exaggeration to say almost everyone gets a biopsy, but a lot of people get a biopsy for a tumor that's largely invisible to us. It's almost like shooting in the dark, isn't it? And hoping not to miss. So in an ideal world, wouldn't it be nice for us to know who needs a biopsy? And once we know that, where to aim. And as I've come to the Pacific Northwest, I realize I'm really a cowboy now, and so who to shoot and where to shoot them. Why is it important? It's important because just a lot of people have it. It's that simple. This is a little dated now from 1999, looking at the worldwide incidence. But in North America, we're the highest because we screen the most. There's no doubt that figure will probably apply to most of Asia, most of Europe as well. You know these numbers. It's the most common non-cutaneous malignancy in men. It's the number 2 cancer killer. This is 230,000 new cases in the United States. Screening tools haven't changed a lot since Osterling put this slide out. And neither of the figures, unfortunately. We still use digital rectal exam and PSA to make our decisions. And of course the sensitivity of the specificity of PSA is remarkably poor with a low positive predictive value. So if you consider, in maybe a little bit of a dated approach, that PSA of less than 4, we know that about a quarter of those men are going to have a positive biopsy rate. And a PSA of greater than 10, 66%. So it's the 4 to 10. Here's an ROC curve. This is taken from it's the most recent one I could find from Belflante, but it hasn't changed that much. This ROC curve was 0.6, which is higher than some, I must say, but still the straight line is the toss of a coin. So reiterating again, about a quarter of men are going to have a positive biopsy. This is the prostate cancer prevention trial that many of you, I'm sure, are familiar with. It really was looking to see whether finasteride could prevent prostate cancer. It had some interesting data that have come from it. I'd like to run through a little bit of it with you. 18,000 men were enrolled in the study to try and give us a power of reducing prostate cancer by about 25%. Those men had to have PSAs of less than 3 at enrollment. They had to be at least 55 years old, and they had to have a normal digital rectal exam. They all had an end-of-study biopsy, partly because finasteride drops your PSA, so they couldn't use PSA as an outcome measure in both arms. Now, it did show almost 25% reduction, which is very, very powerful. Higher grade of carcinoma is still being argued. As you know, when you hormonally ablate the cells from prostate cancer, the grade changes and the vision changes, and therefore this is still being argued. And whether that higher grade in those receiving finasteride is a truism, we're still waiting and still debating. But really, those men with PSAs of less than 3 remarkably also had about a 1 in 4 rate of prostate cancer at diagnosis. So the less than 4s and less than 3s are about the same. In other words, those guys with normal quote-unquote PSAs are almost as likely to have prostate cancer as those with abnormal PSAs. So let's consider the cost, not just in terms of monetary cost, but the cost to the patient. We know that about 8% of men in the United States have a PSA of higher than 4. We know a quarter of them will be positive. If you have 38 million men between 45 and 74 in the United States, that means you've got about 3 million who are going to be able to have biopsies, which means about 750,000 men are going to have prostate cancer if you biopsy them. That means you're going to do you're going to have negative biopsies on 2.25 million men. That's a lot of people. It's a lot of morbidity. But it gets worse. Think about the placebo arm of the prostate cancer prevention trial. After 7 years, men whose PSAs were still less than 4, who had normal digital rectal exams, underwent prostate biopsy. That was 2,900 and a few. 15% of those had a positive end-of-study biopsy. So, what if we screened everyone? Why not? If you screen everyone, 30 million men, we only screened 8% of those, remember. That leaves 35 million men that have been left untouched by our needles. 15% of those will be positive. That's 5.24 million men in the United States diagnosed with quote-unquote prostate cancer, which leaves a total of 6 million in total that we diagnosed, but we biopsied 32 million men unnecessarily. Now this is taking the argument to the extreme, I'll agree. And I also agree that with the title of the talk, Is This the Holy Grail, that there'll be many of you in the audience that may argue with me and say, no, the Holy Grail is probably working out whose prostate cancer is important rather than whether we can image it. And one could go back and forth. One could say, well, if you could image it exactly, then you may not need to treat a lot of these guys, and you could watch it grow and treat the ones who are important. But having said that, I think this poses to you some of the problems associated with PSA. So how do we improve it? We do various things. I talked to you about lowering the cut point. We can do various other things with PSA, looking at free to total ratios, complex as in Brower, and precursor forms. We'll skirt these briefly. Data looking at PSA probability of cancer in the 4 to 10 range, that gray quote-unquote area. If you look at the free PSA, it's really not much better unless you're in the 0 to 10 range. And of course you give up a lot of sensitivity in that range. If you look at the ROC curve from that, this is the Belafonte one, but there are several others, and I'll show you one by Catalone in a minute. This isn't much better than the toss of a coin. It's 0.52. If you look at some of the free PSA precursor forms, the full-length and truncated forms, you look at them expressed as a proportion of free PSA that Catalona did, you can see that they are slightly better. The ROC curve is 0.634, not a lot better, and you can see his free PSA was very similar to the Belafonte. So no matter what we do to PSA, I think you can say that the fact of the matter is we just don't do a lot better. We really don't do a lot better, no matter how we play with it. So I pose to you then that the problem is that individual clinical parameters are really unreliable. And I also pose to you that what you do in the office every day is very likely mental gestalt. That very often you probably say, well, I'm going to base the decision to perform a biopsy on personal experience, knowledge, my prior outcomes, some of which are PSA-based. But all of those have problems because they're subject to inherent biases. Predictive models are not. They maximize predictive outcomes, and they certainly outperform human experts. Many of us are aware of Mike Catan's work when he was at Memorial in developing predictive models. There's a nice story here that Larkin talked about in the Oncology Times, where he actually reported on men presenting with lymphoma to Memorial. And Mike Catan had developed a nice model for lymphoma, and so they did a prospective study of asking the oncologists at Sloan Kettering to predict how these lymphomas would be staged and how their outcomes would be. And they compared it to Mike's model, and Mike's model outperformed it threefold. Did a much better job. So we decided to look at how can we predict men. I develop a model to predict men who are going to have prostate cancer. Can we help that Gestalt theory? Can we do that? So we actually presented this at ASCO. It's been published more recently in the Gold Journal. This is part of a grant that I was part of, the Department of Defense grants, and looking at neural networks to try and predict prostate cancer outcomes. The leader of that was David Crawford, but I couldn't have done any of this work without Colin O'Donnell and Ed Gamita, the two statisticians, and of course Ash Tiwari, a good friend who also worked on the project with us. We developed in our earlier, between 1999 and 2001, a prospective study. We had 319 men who came to us referred for prostate biopsy. It's not a screening population, it's a referral population. I was responsible for all the clinical and ultrasonic exams. Prospectively, we graded them in terms of level of suspicion, where 1 was very unlikely and 5 was very likely to be carcinoma. And we kept quite a bit of data on these referral patients. We kept, as you can see here, not only ultrasound findings, but things like AUA symptom scores and biopsy history and potencies. We decided that we couldn't just do a neural network model because those folks that do logistic regression models would argue with us that it was biased, so we decided to do both. And this will be a theme that you'll see throughout some of the talk today. We selected as inputs on the basis of logistic regression the following variables: PSA, prostate volume, exam findings, graded between 1 and 5, ultrasound findings between 1 and 5, and prior biopsy history. And then, because we had 300 patients, we divided it into 5 subsets and actually made 5 models. And then what we did was we trained the model, and then we used other subset data to validate the model. So the models are always being validated with quote-unquote virgin data. Now, how many are familiar here with neural networks? Using a fair amount of them? So you know they work on a human brain model. Basically, you train the model, and the model learns as it goes along. Importantly, the way to think about it is that the input layers, and I just put PSA, rectal exam, and ultrasound here for an example, but the inputs will go into the nodes, and then the nodes will weight those inputs, feed it to another node with another weight, and then you'll generate an output. And I think the key to understanding this is knowing that this output is known. This is known by the model. And so if you know that output, then the neural network can go back and say, oh, I was wrong on this particular patient. I'll re-weight those inputs so I can get the right answer, and then you get another data set. So it takes each data set individually, re-weights and relearns it. So the weights are adjusted to minimize any error on the output error. Always the models are validated on virgin data. In other words, you never take data that you train the model and give it to. Otherwise, you get 100% every time. So when you read papers on this, it's important to make sure that they've used virgin data, set-aside data. We use ROC curves that you're all familiar with. And these were our results. We took the mean area under the ROC curve. These weren't the best, but they were the means, and we found that they were both very similar, but very, very robust, really, 0.76 and 0.77 for neural networks and logistic regression with very low standard deviation. So we were happy with that, but we decided to move on. I wanted to just bring this up. I don't know whether neural networks are better than logistic regression right now, but they may have some improvements. One is they don't take your numbers and categorize them. They leave them fluid, so you can use a vast variety of inputs on a wide scale and allow the model to adjust to that. So I think it's more of a plastic model. I think it's more useful maybe in real life. I think a lot of people, as you'll see, produce models for PSAs of 4 to 10 or, I don't know, less than 12 or something. But that's not the way patients come in. Some of them come in with PSAs of 19, and then you couldn't use a predictive model that's categorized. The other is they maximize your freedom, and actually the American Joint Committee on Cancer thinks they're a good idea for prostate cancer. So we took another step. I talked with the folks in Austria, and we got their data. And also Joe Presti's data. This was at ASCO last year. It's in press right now. The data sets were relatively large. All prospective sets, the Tyrol data at 3,800, the Mason Clinic and Stanford data sets. And the Tyrol, this is worthwhile just thinking about. The Tyrol study was a screening study. That's different from our data set. It's a screening population. Those patients had age-specific elevated PSAs that stimulated biopsies. When they had an age-specific elevated PSA, they came back for a repeat PSA, a rectal exam, an ultrasound, all of which were graded similar to our levels of suspicion, and then they underwent sextant biopsies. Our population was different. The Mason Clinic and Stanford were different populations. They're referral populations with elevated PSAs or abnormal rectal exams, and they underwent 10 core biopsies. These were the input variables that we used after selecting again by stepwise regression. Very similar to our input variables before. The only addition was PSA density. We took the Tyrol data and we divided into 3 subsets, each 1,200 patients. The remaining were set aside for testing. We developed 3 neural network models and 3 logistic regression models. In the same vein that I told you before, we used something called crossway internal validation on the Tyrol data set. So when you developed the model, you had 2/3 of the model set aside for validation. We then selected the median and applied that with extramural data, which was the Mason Clinic and Stanford, as independent data sets. I'm sorry it's busy, but we'll go through it. I think what I don't have a pointer here, but it doesn't matter. This is essentially Tyrol AB was the model that was developed from the Tyrol randomly split sets of Tyrol A and B. They were validated against Tyrol C data, which was virgin data, and the area under the ROC curve for both neural networks and logistic regression was 0.75. Very, very similar. Thank you very much. Very, very similar, as you remember, to our previous model from the 319 patients. We then took that median. We didn't take the best one. We took the median, and we put it up against the Mason Clinic data, and you can see that using the Mason Clinic data but with extramural validation, it's 0.74. So very, very close in predicting outcome. And similarly with the Stanford data, very, very similar. So, in essence, I think that this is interesting data primarily because it takes a screening population model that internally validates it and then robustly validates it against extramural data in a referral population. So it sort of crosses the line of screening and referral populations. And we'll talk about some of the criticisms. These are the other papers out there. Early paper by Snow using artificial neural networks. We've been in line with Dijavan and others in looking at this. I think one of the things to look at is the PSA range. We have not limited our PSA range because we believe in real life, and you can see our range was 0.3 to 1300 for this model, with very competitive numbers and also competitive results in terms of predictability using area under the ROC curve. This was the only model with extramural validation. The other models didn't have that. I think some of the critique is, well, Dr. Porter, you used the screening population to make your model. How can you do that? Part of it is a very short but trite answer by saying the proof is in the pudding, isn't it? I mean, if you can take and make a model from a screening population and then you validate it with a referral population, it works, then it works. I mean, there's no real argument with the fact that it's working. What about sextant versus 10-core biopsies? Did we pick up less patients in the chiral data? Is it therefore a problem? It is a problem. I mean, using sextant data. However, what I would say is that's not the only predictor of cancer. I think as scientists, particularly urologists, we tend to try and hang our hat on one thing. Well, you have a problem with the sextant data, but this model has a lot of input variables in it. It has age, it has PSA, it has PSA density, it has volume of the gland. All of those are predicting outcome, not just how many cores you take. So despite that, I think you can go back to the results. We still managed to validate the data accurately in an extramural fashion. So now maybe we could tell who we should biopsy, but I don't know whether we can say where we should biopsy them. This is probably something you hear quite often. I know I do. Patients say, let me get this straight. My PSA is between 2 and 10. I have about a 25% chance of a positive biopsy, which means I have about a 75% chance of having a negative biopsy. In response, we say, well, we can't see the cancer, so we'll just take more biopsies. And we miss it a third of the time, so we'll just do it again. Thought you'd appreciate that. So great. Oh no, I know. Absolutely. Or maybe it does in some parts of London. I don't know. In grayscale ultrasound, it's just inaccurate. You know, grayscale ultrasound, we take the sound wave from the this is the probe. You shoot sound up, and then what we do is the sound wave returns, and we say, well, a lot of it returned, therefore we have a white signal, and none of it returned, then we have a black signal, so everything in between is gray. It's a bit like listening to a symphony and only hearing the volume changes. You don't hear any pitch, you don't hear any other changes in it. You just hear the volume. I mean, all that information is there, but it's remarkably inaccurate. 30 to 50% false negative rates reported in the literature. The targets are few. Hypoechoic lesions are anywhere between 40 and 65% reported in the literature, probably because benign disease squeezes the periphery of the gland and squashes those peripherals into isoechoic lesions. My patients say it looks more like a weather map than anything else. It could be anything. This is work that started off really under the brains of a guy by the name of Ernie Filippa and Bill Fair, and was taken on by Peter Stardino. I was a fellow at Memorial under Bill Fair when this was actually underway at that point. Fleischner was doing this before I got there. I continued it after I'd left with Ernie Filippa. These are the two guys. This is Ernie Filippa here, really the brains behind this, and he needs no introduction. Bill Fair. Both of them were scuba diving at the same time. The rationale behind these studies in looking at spectral analysis, ultrasonic spectral analysis, is that we can't see prostate cancer. And we certainly can't target any form of therapy or treatment because we're blind. So our objectives were to characterize the cancerous and non-cancerous tissue and then to image those regions of the prostate with overlays. I think it's pretty obvious why we would like to do this. We want to guide our biopsies. We'd love to be able to treat cancerous tissues and spare non-cancerous tissues. Wouldn't it be great if I could tell Dr. Gleave that this is the area where the prostate cancer is and that drug could be given to that area and didn't have to be given in other areas. You could have a nice concentration of drug. Similarly, you can think of a whole host of other methods of treatment we'll talk about in a little bit. But monitoring treatment is remarkable, and monitoring non-treatment too. Monitoring men, we talked about last night, monitoring men who are undergoing watchful waiting. If you could see the disease, you can do a lot better. This is a cartoon saying how we generate our data. The probe, obviously, the returning sound wave comes back. We harvest the radio frequency echoes, which are taken to our mainline computer. Importantly, the B mode is grayscale. The B mode interpretation is also given a level of suspicion. So in other words, I also, for every biopsy, generate a level of suspicion for whether there's carcinoma there, based upon, it's purely subjective, but it's single operator. So here's the basics of this. The returning sound wave is captured. Instead of just capturing the volume, as I was saying, we capture the whole returning sound wave. In fact, we capture the radio frequency signal. We analyze the slope, y-intercept, and midband of those RF values. We've developed a classifier, which in this case is an artificial neural network that combines not only these values, the slope, y-intercept, and midband RF values, but also combines age and PSA and gland volume. Those are then, we have the region of interest, which is the biopsy zone, and so we know whether there's cancer there or not cancer there on the basis of the histology. We develop lookup tables, and when new radio frequency values are analyzed, we can calculate the probability of cancer being in different glands. This is a returning radio frequency sound wave during an ultrasound of the prostate from our screens. Essentially, this is the radio frequency wave slowed down. This is the intercept, slope, and midband within this area here, called which is the region of interest within the gland. These are the areas that we found to be most predictive: slope and intercept, along with midband. Our general approach was to build the database, in other words, to collect all this information of the returning sound wave signal, to classify the tissue types, and then generate tissue images. So we take the radio frequency values here, they become part of the database, together with some clinical parameters, and as a comparison, we obtain baseline data in terms of level of suspiciency for grayscale to see whether grayscale is comparable. And then we obtain the truth from the histology within that region of interest. This is the setup I use right now to do my biopsies and generate the data. It's a Hitachi N5 probe, the 5500 model. This is a regular grayscale image on this screen, and this image is the spectral analysis image that I generate in real time now. This is some of the early ROC curves that we used to build our database with. This is the best curve, which has an area of 0.84, and this blue curve is the grayscale. area under the ROC curve. So the accuracy of predicting prostate cancer based upon grayscale was 0.66, whereas the accuracy for using spectral analysis was much higher, 0.84. These are our last data sets looking at areas under the ROC curve. You can see that we're significantly better and still quite consistent at 0.81 with a similar level of suspicion on grayscale. This is my last data set. If you look at data from other institutions, when I was at Memorial, this was accuracy again. When I was at State University of New York in Stony Brook, our accuracies were quite similar. And then while I was there, they were still doing this at Memorial. You can see that the accuracies are very similar, very robust. So, spectral analysis, the returning sound wave signal, can offer us an ability to try and identify prostate carcinoma. We have just finished, and that's been funded now by the NIH for 9 years, and we just resubmitted in the last 2 months for more funding. We've also written a new grant that was submitted 2 weeks ago for multi-modality studies for diagnosing prostate cancer. This is in combination with Columbia Riverside Research in New York, where Ernie Filippa is, and the Mason Clinic. We intend to use not only ultrasonic spectral analysis, but also MRI as well as MRS studies, and to validate these in 3-dimensional models with independent validation against the radical prostatectomy specimens. So what I'd like you to think about is that the spectral analysis we realize is important, but we think we need to combine it. I mean, we think we need to open our eyes and look at other technologies too. We'd like to try and combine some of the results of MR and correlate it with our 3D histology. So what we're doing right now is men prior to radical prostatectomy undergo a transrectal ultrasound using spectral analysis. We take step sections every 2 centimeters, every 0.2 centimeters, using a brachy-stepping probe on them. This is done as an outpatient. They then return within a week. They have their radical prostatectomy performed, and then we take, I'd like to say whole mounts. I'm still trying to talk my pathologist into it, but we're taking half mounts now on thin slices and comparing those. This is one of those images. This is from a whole mount that I managed to talk Gillespie into doing at the NIH for us. These are the areas of carcinoma, a multifocal disease, no surprise. Here's the areas under spectral analysis outlined in red. You can see correlate quite nicely with those areas of carcinoma on the whole mount. This is just an example of some of the targeting we did. This was presented at ASTRO 3 years ago, looking at ability to target in real time using spectral analysis for brachytherapy. But in combination with that, we'd like to add MRS. Now, are you familiar with MRS here? Is anybody in Canada using MRS, Martin?
Yeah, a trial going.
You have a trial going right now. I'm sorry for my ignorance. I didn't know. I didn't realize I was in one of the bastions of it. Who's doing it? Dr. Chang. Hi, Sylvia. Well, you can correct me if I say anything wrong here. Essentially, men with prostate carcinoma have decreased levels of citrate on MRS and increased choline and creatine. This is data out of UCSF, which I believe was one of the first centers to do it in North America, looking at areas of carcinoma and healthy tissue here in the same gland quite nicely. Using overlays where green is normal and carcinoma is abnormal based upon citrate and choline images, you can see a normal area of the gland here and carcinoma on this side. And this is his data in 47 patients at UCSF, and I think you can see that with a positive biopsy, the sensitivity is still remarkably high, but specificity is not still that high. So our thoughts were, well, this may not be the whole answer either. Can we combine these overlay images with our spectral analysis overlay images and improve this? And that's the basis of our recent proposal to the NIH. If you look at the ROC curves for MR and MRI, I think you can see that the MR plus MRSI certainly has an improved ability, which is very close to our spectral analysis area under the ROC curve for detecting prostate carcinoma. And in conclusion, I think we can say that the images, certainly the spectral analysis tissue type images I've shown you, that's one with the red dot, certainly show promise. We're now doing a real-time trial where I guide my biopsies under real-time, so the signal comes back and I take half of my biopsies based upon whether there's an increased likelihood of carcinoma at the time of biopsy. We're going to look at MRS and combining it for targeting therapy, and also, and I think very important, monitoring therapy as we diagnose more and more men with prostate carcinoma. I think these are obvious. The payoff is huge. I mean, if we can reduce our missed cancers and have fewer unnecessary biopsies, and these are in the total of millions. I mean, we're not talking about peanuts. These are millions of men not needing biopsies. We can certainly reduce the deleterious effects of non-cancers and certainly identify those men who need to be treated. And I think overall, not only will we know who to shoot, but we're going to know where to shoot them. So, thank you very much.
Thanks, Chris. We have a few minutes for questions. One question I want to ask on your spectral analysis on that one hole mount you showed, is there a difference in grade between the areas that show up on spectral analysis?
It's a great question. We haven't looked at that yet. We've sort of stuck to our guns in trying to maintain cancer from non-cancer, and we haven't broken it down for grade yet. But that's certainly to be done. Yeah.
Ideally, the ideal test is one that can pick up the high-grade tumor.
Oh, you're absolutely right. And MR has that.
Cancer that needs to be treated as opposed to the cancers that don't need. So, do you want to comment on your experiences with MRS, and what we're doing here?
What we're doing is, in addition to histology, we're also assessing the diffusion of the prostate gland, looking at the diffusion of the lower prostate. The theory of that is diffusion images differently in the prostate and imaging the brain and assessing the stroke. The theory there is that normal tissue, normal tissue, the amount of diffusion varies like a Brownian motion, and damaged tissue, damaged cells, and that is to do with a lot of concentrated diffusion normally. And you can pick that out on an MR diffusion, and that's how the tissue goes stroke. We're applying that to prostate cancer, and we're having, right now we've done about small population of patients, but we think that we are seeing correlation where there is abnormal diffusion in the types of prostate cancer. Similarly, we're also looking at contrast enhancement.
How do you measure the diffusion?
That's a good question. We have the older MR physicists who calculate already, but
clever people, right?
got it all recorded.
Only two people in the world.
That's right.
Holding out the microphone.
Okay.
One of our theories is that the reason we went down the tube, and I asked Piotr to work out these fancy mathematical models. I can share the mathematical model with you, like got a lot of squiggles.
I don't understand it. I don't think I'll understand it.
All kinds of numbers in it. I show it when I give that talk. I show it when I said, see this what's here, and it's totally confusing. Anyways, I mean, if you think of it, high-grade tumor looks different under the microscope than low-grade tumor, which looks different than normal tissue. Therefore, the diffusion of water molecules, you think, at least intuitively, would be different between the glands of the tissue. And so we're looking to see whether or not we can detect differences and not necessarily correlate. Okay, this is a high-grade tumor, or this is a low-grade tumor, but we're going to say this is a high diffusion tumor, this is a low diffusion tumor, this is a non-diffusion tumor, and then look at outcomes later on. That's the eventual goal. And it's not dissimilar to what you're doing with spectral analysis. I suspect that spectral analysis is a little easier to do than MRI, which is what about an hour of the patient in the magnet? 45 minutes?
Yeah.
It's a lot of time for the patient. It's not an easy test to do on the patient. So Martin and then Joel.
Andrew McNeely has, always wondered about these neural networks and prostate cancer. So let's say that, we have a patient who has a bunch of parameters, and we, outside of your studies, wanted to access a neural network and plug in his 6 or 7 parameters and get a predictive value. How do we actually do that in real life?
Oh, you mean for a patient in real time?
Yeah.
No, that's a great question. In fact, ours is going on the web right now. You could do that. I mean, it will very soon be on the. It's on the website from that grant study called andincap.org. I can give you that. Andincap.org. So you can put that in and generate a probability of there being a positive biopsy. Now the question is, what do you do with that? I mean, I think that's a fundamental question. Do you believe it? I think the onus in terms of diagnosing prostate cancer is certainly higher. The responsibility, if you like, is higher for us on the diagnostic end than it is for those predicting outcomes from stage, for example, from Alan Parton's work, or even Mike Catan's work, because we're going to tell you not to do a biopsy, which may influence the guy's diagnosis, whereas theirs is just going to alter his outcome. So, I mean, I think that it's a fundamental question that we're proposed. Can you use ours? Is it accurate enough? Is 75% accurate enough?
Here is particularly, most poignant in the U.S. I mean, I don't think we're as. I think that it's most important to actually reduce the number of biopsies.
Yeah.
Reduce the number of biopsies. We're diagnosing too many cancers, and we're aware of that. If you don't biopsy on one occasion, it doesn't mean that you stop following it.
Right.
You keep following it, and the cancer might be diagnosed in a year or two. The chance of missing an important cancer in that period of time is still very small.
Yeah.
I know that there's a medical legal aspect of a 2-year delay, and whether or not that will come back to haunt you, but I think that for the greater good, we have to reduce our trigger point.
Joel and then Anthony.
Not to minimize the importance of the data facility as a devil's advocate, what your basic thrust of it is that you're trying to reduce the morbidity of biopsies because patients sometimes have biopsies. Yet the main thing that patients don't like in a biopsy is having a probe stuck up the rectum, and the actual biopsy itself is perhaps not that big a deal, probably on the probe being out there for 10 to 15 minutes. So now we're talking about let's do an MRA, and then MRI, and let's decide at the basis after 2 probes being stuck up the rectum whether or not you should have a biopsy. From the patient's perspective, you might be reducing more morbidity of the actual biopsy than the biopsy itself.
Right, it's a very good point. First of all, I think it's a debate whether the probe is worse than the needle or not. So I think we could probably agree to disagree that there's a 50-50 shot there. In terms of your comment about MR, the MR studies are not just for diagnosis. I mean, our goal is to look at to actually image prostate cancer, so that we can hopefully, and on the other end of the scale from your argument of diagnosis, which you picked very reasonably to set the argument, but on the other end of the argument was, well, if we can image that cancer and the guy doesn't have to have his prostate gland taken out for the sake of a couple of endorectal probes, then perhaps we've done him a lot of good, and we can follow him expectantly. So I think that if we were only looking at biopsies, and if I portrayed that, I'm sorry, we're looking at not only biopsies but also targeting therapy as well as sparing non-cancerous tissue as well as monitoring treatment, then I think that probably the reason of having a couple of probes probably outweighs the risk and discomfort. But your point's well taken, yeah.
I was interested in how you're using your neural networks, how your positive and negative predictive values compare to traditional methods of DRE or PSA, because the numbers seem like 0.3 or 0.4, even though the ROC curve numbers are pretty good. Yeah.
They are. In fact, if you look at individual parameters, individual parameters just tells you you're going to have a positive and negative biopsy. It doesn't tell you where. Are you with me? So for the digital rectal exam, those positive predictive values are really for all comers over the entire gland based on Sextant or 10-core biopsies. You don't know where that disease is. So DRE predicts that. It only predicts a positive biopsy overall. It doesn't say where. These are ROC curves are saying not only that there's cancer there, but where the cancer is. Maybe, maybe not. Now, if you can image the cancer, and don't forget we're trying to image the cancer. If you can image it, then maybe the treatment would be the same for 5 years. And I'm pretty confident in saying in 10 years it probably won't be. I mean, I think if I could tell you that your cancer is located in the right base and is 0.2 cc's, and I'm very sure of that, then would you be willing to undergo some form of minimally invasive therapy?
I'm more interested in making the decision to do whether or not to do a biopsy rather than where it is, but that's the initial data part of your presentation.
So you mean in terms of the artificial neural networks? If you look, I think you have to look at area under the ROC curve. It's the best predictor of that. I don't think positive predictive value is as good as area under the ROC curve for a test, and that's why ROC curves are used universally throughout the FDA for all forms of testing. I think positive predictive value is nice for individual levels, but I don't think it gives you the whole picture. It doesn't really compare them as well.
The selective treatment is already being looked at just based on biopsy. The selective brachytherapy or selective cryotherapy just for the area of the tumor.
The main difference between positive predictive value and ROC is that the positive predictive value of the same test is changing in different populations depending on the prevalence. ROC is constant. It's an intrinsic property of the test. So that's why.
Yeah. Thank you. Yeah.
Very good. All that training comes through. Mike?
I would look on the future of imaging, and it's not so much more targeted therapy of the prostate. The prostate's a disposable gland, regardless. And whether or not you reduce the toxicity of brachytherapy by limiting it to half the gland, I think is probably not as big an upswing, especially when you think that cancer is multifocal, it's still a field effect, and it might affect another part of the gland if you only treat one part of the gland. So I think that the biggest potential for imaging is the ability to image biology and stratify for risk of progression or follow when progression occurs, because you're predicting less tests in some ways metabolic activity or proliferative activity of the tumor. So does either of your modalities, whether or not spectral analysis or Sylvia can comment, MRS actually predict for metabolic activity or proliferative activity of the tumor?
I don't know yet. The answer is that we haven't looked at that yet, Mark, and we haven't looked at the grade of the disease. We haven't looked at the ability for angiogenesis, for example. I mean, there's some things we could look at. I think we're still relatively new, and we've been doing this for 9 years, but we haven't looked at some of those things, and those are great ideas. Yeah.